Basic Electrocardiogram Monitoring Medical Emergencies, Chapter 17 and 9. Introduction. In the mid-1800s, it was discovered that the heart's electrical activity could be measured externally by placing the electrode on a person's skin. In 1901, Dr. Enthoven improved the heart's measurement with electrical activity with a timed record. It was named these measured waves, or rhythmic movements, the P, QRS, and T waves. It was named electrocardiogram, EKG, or also known as ECG. A review of cardiac anatomy. The heart is a fist-sized muscular organ that is located in the left side of the body between the lungs and the mediastinum. It is a double pump. Its purpose is to pump deoxygenated blood through the heart to the lungs for reoxygenation, and then to pump reoxygenated blood back through the heart into the aorta into all body tissues. The heart has 4 chambers, right and left atria, and right and left ventricles. The cardiac conduction system. The ECG reports the electrical activity of the heart, particularly the contraction of the myocardium. It supplies information concerning the heart's rate and rhythm. Electrical stimulation results in contraction of the heart. Depolarization acts as a wave throughout the myocardium and results in contraction of the heart. Repolarization takes place as the cells return to a resting state. The SA node, located in the upper posterior wall of the right atrium, is the dominant pacemaker of the heart. So again, SA node, dominant pacemaker. At rest, under normal conditions, the SA node initiates 60 to 100 impulses per minute. It is responsible for the rate and rhythm of the cardiac cycle. A normal cardiac cycle. From the SA node, the wave of depolarization is carried through the right atrium to the left atrium and results in nearly simultaneous contraction of the right and left atria. The atrial conduction system has 3 internodule tracts in the right atrium and 1 conduction tract in the left atrium, called Bachmann's bundle, which depolarizes the left atrium. Depolarization is then conducted to the AV node. The AV node is located in the right atrial valve near the tricuspid valve and coordinates the incoming electrical impulses from the atria. After a brief delay, which the atria contracts and completes filling the ventricles, the impulse is conducted to the bundle of His. The bundle of His is a group of cells that travel through the ventricle septum. It divides into the right and left bundle branches and conducts impulses to the right and left ventricles. The left bundle branch bifurcates into the left posterior bundle branch to reach the terminal point in the conduction system, the Purkinje fibers. At this point, the myocardial cells are stimulated and result in ventricle contraction. This cell-to-cell passage of impulse is the conductivity. When the impulse spreads to all areas of the heart, the action potential is called excitability. This leads to the shortening of the myocardial cells and contractibility. The heart rate is determined by the myocardial cells with the most rapid firing rate. Electrophysiology of the cardiac cycle. The depolarization-repolarization cycle goes through 5 phases, which can be seen as it registers on the ECG monitor. When the electrical activity of the heart is normal, it is referred to as being in normal sinus rhythm. Phase 0, Phase 1, Phase 2. This is a diagram demonstrating ECG, or EKG. Lead placement. The 2 leads most often used for continuous monitoring are lead 2 and a modification of V1 through MCL. Lead 2 demonstrates atrial depolarization. MCL demonstrates ventricular activity. If a third electrode is used, it may be placed anywhere on the upper anterior chest. Whenever the electrodes are to be positioned, the patient's skin must be prepared by removing the dirt and oils present with soap and water or alcohol. Hair in those areas is sometimes removed by a physician's order to reduce skin resistance. The electrodes are placed flat on the skin. Make sure electrodes have lubrication. Once the electrodes are in place, set an alarm on the ECG machine for 30% above and 30% below the patient's baseline heart rate. The ECG is used to detect cardiac dysrhythmias, conduction disorders, myocardia ischemia, injury and infraction. A deviation from normal sinus rhythm may indicate a life-threatening emergency. Sinus and symptoms: anxiety, chest pain, altered level of consciousness, increased heart and respiratory rate, lightheadedness, cool, pale, moist skin, shortness of breath. Potentially ominous ECG dysrhythmias: sinus bradycardia, ventricular and atrial rates less than 60, sinus tachycardia, rates over 100. Again, remember brady means below and tachy means above. Atrial flutter. Symptoms are SOB or hypotension. Atrial fibrillation, rapid thrombi or stroke. Ventricular fibrillation, heart rate not audible. Third degree AV block, may not have symptoms. Ventricular asystole. Cardiac emergencies. You can also see examples of this in 17-2 in your book. Antiarrhythmic, thrombolytic, analgesic, and others. And below is ECG artifacts that you can see. Medical emergencies. Introduction. Patients arriving in the diagnostic department could be experiencing a variety of ailments. Non-trauma related emergencies are most likely to occur while the patient is undergoing a procedure. Observing and communicating with your patient is important. In most cases, the first action that you should take in a life-threatening emergency is to call the hospital emergency team, the physician conducting the exam, and a coworker for assistance. Emergency. Situation in which a condition of a patient or sudden change in medical status that requires immediate action. Radiology objectives: preserving life, avoiding further harm, obtaining medical assistance ASAP. Need to be able to recognize situations and when it is necessary to call for medical assistance, which should be your first step. General priorities: ensure an air opening, control bleeding, take measures to prevent or treat shock, attend wounds or fractures, provide emotional support, continually reevaluate and follow up appropriately. What type of emergencies? Shock, anaphylaxis, which is a type of shock, pulmonary embolus, reactions related to diabetes mellitus, cerebral vascular accident or CVA, cardiac and respiratory failure, syncope, and seizures. A crash cart, a cart that contains medications and equipment that are needed when a patient's condition suddenly becomes critical. Every department has one or more. Know where they are located. Assessment of levels of neurologic and cognitive functioning. During the care of a patient, you must be able to assess the patient's condition. It is not within your scope of practice to assess the neurologic condition. However, knowing what to look for will help you be aware of patient assessment. Glasgow Coma Scale. This scale addresses the 3 areas of neurological functioning and gives an overview of the patient's responsiveness. Are the eyes open? What is their motor response? Verbal response. Levels of consciousness, also known as LOC. Alert and consciousness. Least severe, responds to questions and other stimuli. More seriously injured become drowsy. Can be roused with loud speaking and touch. Unconscious, which is a serious injury, reacts only to pain stimuli, pinches and pricks. And then comatose, which is most severe, unresponsive to all stimuli. Deteriorating situations. Indications: drowsiness, irritability, lethargy, slowing pulse rate, and slowing respiratory rate. Intoxicated patients require extra precautions. They may not just be passed out. When in doubt, get assistance. Responses: maintain open airway, move as little as possible, stop procedure and get help, and take vital signs. Shock. Shock is the body's pathological reaction to illness, trauma, or severe physiological or emotional stress. It may be caused by body fluid loss, cardiac failure, decreased tone of the blood vessels, or obstruction of blood flow to the vital body organs. Shock is a life-threatening condition that may occur rapidly and without warning. Types of shock. Shock continuum: hypovolemic, due to loss of blood or tissue fluid. Cardiogenic, due to cardiac disorders. Myocardial infarction, also known as MI. Distributive, due to the blood vessels' inability to constrict and their resultant inability to assist in the return of the blood to the heart. Can also be through anaphylactic shock. Obstructive, due to the pathological conditions that interfere with the normal pumping action of the heart. Neurogenic, spinal anesthesia or damage to the upper spinal cord. Vasogenic, sepsis, deep anesthesia, or anaphylaxis. Hint: These may be good terms and definitions to study for. 3 types of distributive shock: neurogenic, loss of sympathetic tone, causing vasodilation of peripheral vessels; septic, caused by a gram-negative bacteria organism; anaphylactic. The type of shock is a type of vasogenic shock and is most common in the department due to iodinated contrast media. It is the result of an exaggerated hypersensitivity reaction to an exposure or re-exposure to an antigen that was previously encountered by the body's immune system. Radiographer's responsibility: a complete medical history prior to administration of iodinated contrast media, such as food allergies, mainly shellfish, medication allergies, previous incidences with past contrast agents. Additional questions can be displayed on 9-3. Clinical manifestations: was it mild, moderate, severe? Anaphylactic shock: type of vasogenic shock and is encountered with the administration of iodinated contrast media, or it's an allergic reaction and it can be mild to severe. Most severe reactions can result in death. Adequate history can prevent occurrence. The longer it takes for the reaction, the less severe it is. Constantly monitor your patients. Mild systematic reaction: nasal congestion, periorbital swelling, itching, sneezing, tingling or itching at the site of the injection, feeling of fullness or tightness of the chest, mouth, or throat. Moderate systematic reaction: all symptoms listed above with rapid onset: flushing, feeling warm, itchy, and urticaria; bronchospasm and edema of the airway or larynx; dyspnea, cough, and wheezing. Severe systematic reaction: all symptoms listed before, but with an abrupt onset: decreased blood pressure, weak, thready pulse, severe dyspnea and cyanosis, dysphagia, abdominal cramping, vomiting, diarrhea, seizures, respiratory and cardiac arrest. Medications for anaphylactic shock: epinephrine, diphenhydramine, hydrocortisone, amniphylline. Documentation: if the patient does experience an anaphylactic reaction, the radiographer is responsible for putting a sticker stating allergy reaction on a patient's X-ray chart or jacket, or documenting it in the PAC system. Pulmonary embolus. A pulmonary embolus is an occlusion of one or more pulmonary arteries by a thrombus or thrombi. This is a common emergency, which results in more than 50,000 deaths each year. They are associated with trauma, abdominal surgery, pregnancy, congenital heart failure, or prolonged immobility. Diabetes emergencies. Diabetes mellitus is not recognized as a group of metabolic diseases resulting from a chronic disorder or carbohydrate metabolism. It is caused by insufficient production of insulin or inadequate utilization of insulin by the cells of the body. The result, an abnormal amount of glucose in the blood, or hyperglycemia. 4 major types of diabetes mellitus. Type 1, diabetes mellitus, is under the age of 30, abrupt onset, insulin by injection. Type 2, patients older than 40, gradual onset, can be controlled by weight loss diet and exercise, but must be controlled. Type 3, associated with or produced by other medical conditions or syndromes. Type 4, gestational diabetes, occurs in the later months of pregnancy, controlled by diet, but insulin may be given. Acute complications of diabetes mellitus: hypoglycemia, diabetic ketoacidosis, hyperglycemia, hyperosmolar, non-ketotic syndrome. Hypoglycemia. Excessive insulin is present. Results from patient taking dose of insulin and not having a normal breakfast. If no food is eaten, administered insulin depletes body's energy store, leading to insulin shock, which is the reaction. Patient may experience intense hunger, weakness, and shaky excessive sweating, may be confused and irritable with aggression and hostility, need a quick form of carbohydrate or glucose. Hyperglycemia is a condition of excessive sugar in the blood associated with diabetes, develops gradually over several hours to days. They may have excessive thirst, urination, dry mucosa, rapid deep breathing, drowsiness, and confusion. Leads to diabetic coma if untreated. needs insulin. Cerebral vascular accident or stroke. CVAs are caused by occlusion of the blood supply to the brain, rupture of the blood supply, rupture of a cerebral artery, resulting in hemorrhage directly into the brain tissues or into the spaces surrounding the brain. Strokes are now being termed brain attacks and are recognized as a medical crisis as a heart attack. Clinical manifestations: severe headache, numbness, muscle weakness, flaccidity of face or extremity, eye deviation, confusion, dizziness or stupor, difficult speech, dysphagia, or no speech, aphasia. Which modality best demonstrates a CVA? That would be CT. Cardiac and respiratory emergency. Respiratory failure, cardiac failure, also known as cardiac arrest. You may be the first healthcare worker to witness this event, so it will be your responsibility to call the code and initiate emergency action. The human brain can survive without oxygen for only 2 to 4 minutes. All healthcare staff must be prepared to perform basic CPR, abdominal maneuver, and use of the automated external defibrillator, or AED. Cardiac arrest: when the heart fails to beat effectively, the blood cannot circulate throughout the body, and the person no longer has an effective pulse. Respiratory distress. Asthma exhibits wheezing due to dilation of bronchi and inspiration and collapse of exhalation. Chronic: most use an inhaler or a bronchodilator. A calm, confident manner should be used. Do not want the patient to increase anxiety that further interferes with their breathing. Choking: a person choking and cannot speak usually clutches their throat and becomes red in the face, which is the universal sign. Encourage coughing. If ineffective, then the Heimlich maneuver is going to be used. Heimlich maneuver: increase intrathoracic pressure sufficiently to propel lodged object out of the throat. Stand behind the victim, wrap your arms around, clutch fist with hand, thumb side in toward the abdomen, pressure excreted inward and upward, quickly 6 to 10 times until the object is expelled. If the patient becomes unconscious, place supine, kneel astride the victim, place heel of hand on the abdomen, other hand directly on top first, and apply pressure and quick upper thrust. Pregnant patients, chest thrusts are used instead of abdomen. Infants younger than 1, a combination of back blows and chest thrusts are given. Held a long length of arm with head lower and supported by holding the jaw. Deliver 4 back blows between scapula and then turn over and deliver 4 chest thrusts with 2 to 3 fingers. Cardiac arrest: sudden stoppage of cardiac output and leads to permanent organ damage or death. Death reduces since CPR and AEDs. Complain of crushing chest pain that radiates down the left arm. CPR should be given immediately. Damage occurs within 4 to 6 minutes without oxygen. Think of cab should be used. Airway, breathing, and circulation. One-person rescue: establish unresponsiveness and call for help. Position to the back for CPR. Open the airway. Establish breathlessness. Perform rescue breathing. 2 deep breaths for 1 second. Establish circulatory inadequacy. Perform chest compressions 30 for 2 breaths. Reassess after 4 cycles. Two-person rescue: each rescuer independently performs compressions or ventilations with switching of positions. 100 compressions per minute, cycles of 30 compressions and 2 breaths. Infants, smaller breaths are used, 2 to 3 fingers instead, and 2 breaths per 15 compressions. Considerations: if in doubt, begin CPR, unless they are DNR. Basic life support is continued until the victim resumes respiration. A physician or healthcare provider calls halt or rescuer is too exhausted. Improper can it lead to inefficient and or hazardous. So, hint, things that may happen during CPR are rib fractures, fractured sternum, and fat emboli. Automatic external defibrillator, public access defibrillator or PAD, reduction in mortality from cardiac arrhythmia. 2 primary types: fully automatic, analyzes patient's cardiac rhythm, determines if defibrillation is necessary, and delivers shock. Semi-automatic, analyzes patient's cardiac rhythm, determines if defibrillation is necessary, and tells person to deliver the shock by pressing a button. Seizures, an unsystematic discharge of neurons of a cerebrum that results in an abrupt alteration in the brain function. Seizures are a syndrome or symptom of a disease, not a disease in itself. Two types of seizure: generalized or partial, which can be complex or simple. Syncope, also known as feigning, in a loss of consciousness which usually results from insufficient blood supply to the brain. Orthostatic hypotension is an abnormally low blood pressure occurring when a person stands up before the blood pooled in the extremities has time to circulate to the upper body. The radiographer's response to pain. Be sensitive to the patient's need for pain control. In 1999, JCOA established standards for pain management for all patients. Find out the policies in your hospitals. Factors that affect pain: age, children and elderly, gender, culture, mental status. The agitated or confused patient. Patients with emotional and mental problems, combative or aggressive, confused elderly patient, or intoxicated patient.